Hospitals are designed to preserve life, stabilize trauma, and bring clarity to biological chaos through science. But beneath the healing floors, some basements preserve something medicine cannot diagnose or remove. Welcome back to True Terror Files Official, where we examine documented encounters that defy rational explanation. Tonight, we descend into 3 hospital basements where medical science reached its limit. These accounts involve only 3 primary witnesses, all trained professionals grounded in clinical procedure. Dr. Emily Carter was a second-year internal medicine resident known for precision and skepticism. Mark Sullivan served as senior night security supervisor with 15 years of hospital experience. Daniel Brooks worked as a maintenance technician responsible for infrastructure diagnostics and structural inspections. The first incident began when Brooks received a digital alert regarding an unregistered power draw below sublevel 2. According to hospital blueprints, sublevel 2 contained only storage and inactive service corridors. Brooks accessed the restricted stairwell at 1:12 a.m., carrying a tablet loaded with updated schematics. The air temperature dropped noticeably as he descended, despite stable climate control readings upstairs. His tablet briefly glitched, displaying a room number not present in official architectural plans. The label read Ward C19, though no such ward existed in hospital documentation. Following the corridor mapping error, Brooks located a metal door partially concealed behind utility piping. The door appeared older than surrounding infrastructure, painted with faded surgical symbols. When he opened it, he discovered a tiled chamber containing a single stainless steel examination table. The overhead light flickered despite electrical lines testing within normal parameters. Brooks heard rhythmic thumping, resembling distant mechanical ventilation, echoing from inside the room. The sound resembled lungs struggling against fluid obstruction. He searched for ventilation equipment, but found no installed respiratory devices nearby. His tablet recorded minor vibration spikes, synchronized with the thumping sound. As he stepped closer to the examination table, the thumping stopped abruptly. In its place came a low, wet, dragging noise from beneath the floor drain. Brooks withdrew immediately and reported the anomaly to security supervisor Mark Sullivan. Sullivan reviewed surveillance footage covering sublevel 2 during the time frame. Cameras displayed brief distortion whenever Brooks approached the concealed door. No one else appeared entering or exiting that corridor for hours. The room labeled Ward C19 vanished from the tablet's blueprint overlay the following morning. Administration attributed the glitch to mapping software corruption. The second nightmare began 3 weeks later during Dr. Carter's overnight rotation. She received a missing patient alert triggered by a biometric tracking implant. The implant registered movement within a sealed basement wing scheduled for renovation. Sullivan accompanied Carter to verify the tracking anomaly before escalating emergency protocol. The biometric signal indicated a patient previously discharged 2 days earlier. Sealed wing required dual authentication to unlock. Once inside, Carter noticed a strong antiseptic odor mixed with something metallic. The biometric signal grew stronger as they approached the inactive morgue corridor. Refrigeration units lined the wall, all powered down for years. Yet a faint rhythmic pounding echoed from inside one stainless steel compartment. Carter placed her hand against the cold surface and felt vibration consistent with a heartbeat. Sullivan checked power access panels, confirming no electricity fed the unit. The pounding intensified momentarily, matching average adult cardiac rhythm. Carter opened the refrigeration door cautiously, expecting mechanical malfunction. Inside was nothing but empty shelving and dry condensation residue. The biometric tracking signal immediately ceased once the door opened fully. Surveillance review later showed Carter and Sullivan reacting simultaneously to a sound not captured on audio logs. Hospital IT specialists found no system error explaining the implant's basement location ping. The discharged patient's device registered inactive during the entire incident. Carter filed a confidential report citing sensory anomaly without clinical explanation. The third and most disturbing case occurred during a scheduled power grid maintenance failure. Carter, Sullivan, and Brooks were present when emergency backup systems activated abruptly. An elevator transporting surgical supplies stalled between sublevel 1 and sublevel 2. Carter and Sullivan were inside when interior lights cut to emergency red. Brooks monitored the mechanical system from the control panel below. Inside the elevator, Carter reported a sudden drop in ambient temperature. Sullivan attempted radio communication but encountered severe signal interference. In the darkness, Carter felt pressure against her surgical glove as if guided by unseen hands. She later described precise clinical touches along her forearm. Sullivan heard metallic scraping consistent with surgical instruments contacting a tray. However, no surgical equipment was present inside the elevator compartment. Carter felt a brief, sharp sensation across her sleeve, but no tearing sound. When power restored, the elevator resumed normal function without mechanical damage. Upon exiting, Carter noticed a clean, linear incision through her sleeve fabric. Beneath the fabric, her skin displayed a superficial cut mirroring standard surgical technique. There was no bleeding beyond minimal surface disruption. Brooks confirmed no sharp surfaces existed within the elevator interior. Security cameras recorded minor flickering, but no visible intruder. The incision healed unusually fast, without infection or swelling. Carter struggled to rationalize the precision of the cut without visible instruments. Sullivan reviewed archival records of the hospital's early experimental surgical programs. Historical documentation referenced underground procedures discontinued after ethical review. Some basements had been sealed permanently during structural redesign decades earlier. Brooks compared historical floor plans to current digital schematics. Several rooms from original blueprints were absent in modern files. Temperature data logs from sublevel 2 showed unexplained fluctuations during each incident. Medical peer review committees declined to formally evaluate the reports due to insufficient measurable evidence. Anonymous hospital staff later referenced similar unexplained experiences in basement corridors. Some described hearing oxygen regulators cycling in rooms no longer connected to pipelines. Others reported seeing surgical lighting flicker briefly through sealed concrete partitions. Carter began avoiding isolated basement consultations unless accompanied. Sullivan increased patrol frequency below ground level despite administrative skepticism. Brooks installed additional vibration sensors, though none recorded repeat thumping events. None of the three professionals could fully dismiss what they experienced. Each event involved physiological mimicry, beyond mechanical explanation. The hospital above remained a place of healing and controlled science. Yet below, anomalies persisted beyond diagnostic capability. Could residual energy from experimental procedures imprint on physical infrastructure? Why did biometric systems and medical equipment register signals with no biological source present? How could precise surgical markings appear without tools or visible operator? Medicine prides itself on measurable evidence and peer-reviewed validation. But what happens when anomalies bypass instrumentation entirely? On True Terror Files Official, we preserve these accounts without exaggeration or dismissal. These witnesses remain licensed professionals bound by clinical ethics. Their testimonies are documented, not dramatized. Would you trust a hospital basement blueprint completely after hearing these cases? Would you descend alone into a sealed sublevel at night? Share your analysis and theories in the comments below. Subscribe to True Terror Files Official for more documented encounters beyond scientific certainty. And remember, sometimes what lies beneath the healing floors is never truly discharged.